Welcome to this medicine masterclass on Addison's disease. Addison's disease is an endocrinopathy caused by adrenal insufficiency in which sufficient steroid hormones, the glucocorticoids and mineralocorticoids, are not produced. And you can see the adrenal glands sitting just above the kidneys. This results in multi-system manifestations. The skin may be hyperpigmented, the cardiovascular system may demonstrate low blood pressure, the patient may complain of weakness or weight loss. The gastrointestinal symptoms include nausea, diarrhea, vomiting or constipation, as well as intermittent abdominal pain. The skin may demonstrate vitiligo. Importantly, in an adrenal crisis, which is a medical emergency, the patient may appear confused, syncopal, febrile, hypoglycemic, hyponatremic, hyperkalemic, and would require the administration of urgent intravenous steroids. The adrenal glands can be divided into the adrenal cortex and the adrenal medulla. The adrenal medulla is involved in stress hormones, the production of noradrenaline and adrenaline. The adrenal cortex has three distinct regions: the zona glomerulosa, fasciculata, and reticularis. The glomerulosa is involved in producing mineralocorticoids such as aldosterone. The fasciculata produces glucocorticoids such as cortisol, corticosterone, and cortisone. And the zona reticularis is involved in producing androgens. In Addison's disease, there is destruction of the adrenal cortex. As a consequence, there is a deficiency in glucocorticoids and mineralocorticoids, such as cortisol and aldosterone. In the UK, the commonest cause is autoimmune disease, or iatrogenic, due to excessive steroid administration, which causes adrenal atrophy. Other causes include tuberculosis, adrenal metastases, lymphoma, as well as adrenal hemorrhage as a result of advanced septicemia, which can occur in Waterhouse-Friedrichsen syndrome. As a consequence of reduced glucocorticoids and mineralocorticoids, the patient may experience the non-specific symptoms include fatigue, lightheadedness, particularly on standing, due to the inability to maintain postural blood pressure. The patient may also complain of muscle ache, muscle weakness, headaches, as well as nausea, vomiting, diarrhea. When hyponatremia is sufficiently low, patients may crave salty foods. Clinically, the patient may appear hyperpigmented. This is because the consequence of the feedback loop increases the drive to generate more ACTH. ACTH is cleaved from POMC, which stands for pro-opiomelanocortin. This is cleaved in a 1-to-1 ratio with ACTH and MSH. MSH goes on to stimulate melanocytes, leading to pigmentation, particularly in the buccal or oral region, palmar creases, in recent scars, as well as the vermilion border of the lips. The neurological consequences include depression and psychosis, and the GI consequences include nausea, vomiting, and abdominal pain. In order to investigate this condition, Usenes would demonstrate hyponatremia and hyperkalemia. Patients should undergo the short Synacthen test, as well as assessment of other adrenal antibodies, including 21-hydroxylase adrenal autoantibodies. A plasma renin and aldosterone ratio would demonstrate raised renin with low aldosterone. Glucose may be low due to decreased cortisol. The screening test is an early morning cortisol concentration. If the early morning concentration of cortisol is reduced less than 80 millimoles per litre, that would strongly suggest adrenal insufficiency. You would usually expect levels of 275 to 555 or above this. The short Synacthen test is an outpatient test that can help exclude Addison's disease. Firstly, the patient's cortisol levels are checked. If they are low, the patient is given Synacthen. This is administered intramuscularly, and the plasma cortisol levels are measured circa 30 minutes after administration. This test is not used in pregnant patients or those who have had recent pituitary surgery or patients on steroids or drugs that can interfere with the hormones being tested. The interpretation: a normal response is a serum cortisol will rise significantly, and this will exclude primary adrenal insufficiency because the adrenals have responded to the exogenous ACTH, but this would not exclude ACTH deficiency. If there is a decreased cortisol response, this may be due to primary adrenal failure, that's Addison's disease, or adrenal atrophy, which may be secondary to long-term steroid therapy. To manage these patients, it's vital that steroids are replaced. Both hydrocortisone and fludrocortisone are administered. It's important to recognize the importance of this condition, to give the patients a steroid card or a bracelet, advise them to increase their steroids before strenuous activity, to double their steroids in febrile illness, injury or stress, never stop the steroids abruptly as that can precipitate an adrenal crisis. The patient should also have in-date syringes of intramuscular hydrocortisone in case the patient is unable to tolerate oral route due to vomiting. In an emergency, patients should seek urgent medical help for intravenous steroid therapy. Thank you for attending this medicine masterclass.